I'm curious what our co-panelists think about the cardiovascular model, because indeed, with an equally prevalent global problem and broadly available medications, including aspirin and others that are off patent, prevention's been developed in that setting and broadly applied. I'm just curious about a show of hands. How many people in this room take aspirin every day? Right. So this may have an effect on cancer risk, but it has been demonstrated to have a prevention effect, at least in subpopulations, on cardiovascular risk. And we've been able to prove that and get very broad acceptance of this. I think it's a pretty remarkable thing. Now, there are at least a dozen people among the grantees who work in areas either directly in prevention or partially in prevention, and might comment on that. I wonder if any of them want to make some points. John.
Well, I think the audience should be aware, starting with the breast cancer mortality in the American Cancer Society statistics. If you project the curves down, it's a linear trend. It's been an unrelenting linear trend since 1990, about 2% a year, and it hits zero around 2040. The figure is almost exactly the same for the UK and Australia, so it's probably real. And the challenge we have is to make the curve steeper. But it's not forever. This is no more deaths from breast cancer. With respect to the cardiovascular model, there are lessons for breast cancer which we're all aware of and we want to try and apply. One is they have a massive risk factor, smoking. We have nothing like that in breast cancer, but we have to find them. Second, they've got biomarkers that predict risk, and you can treat the biomarker. And in cardiovascular disease, they're cheap and reproducible. One is hypertension, another is cholesterol. We don't have those things in breast cancer. So you can see how we could get that curve going down more steeply. The diagnostic processes are good, and in the end, you can take the whole organ out and replace it. And it's a vital organ for survival, which the breast isn't. So I'm very, very optimistic about what can be achieved.
Hal, I'll come to Walter. So what you guys are tapping into or seeing is there's a tremendous amount of prevention research and a tremendous number of ideas in this room already underway. So Powell.
So yeah, I'm a medical oncologist who's devoted totally to prevention and putting us out of business. And I see a convergence of what you're hearing today. There's huge advances in genetics and the ability to do genetic evaluation and find out who's at risk for cancer. And there's huge advances in drug development and understanding targeted therapies. But we haven't made these converge so that we can prevent the disease before it happens. But we're on the verge of doing that. And I think your example of the cardiovascular model is a good one. There's another model of devoted totally to prevention and putting us out of business. And I see a convergence of what you're hearing today. There's huge advances in genetics and the ability to do genetic evaluation and find out who's at risk for cancer. And there's huge advances in drug development and understanding targeted therapies. But we haven't made these converge so that we can prevent the disease before it happens. But we're on the verge of doing that. And I think your example of the cardiovascular model is a good one. There's another model of osteoporosis, which is the same deal. And there's lessons here. In cardiovascular prevention, we're using drugs to prevent death from heart attacks. But we've changed the terminology. You take a drug to treat your high blood pressure. You don't think of it as treating death from heart attacks. And in the case of osteoporosis, you take a drug to prevent osteoporosis, when in fact you're taking it to prevent bone fractures. So in cancer, we don't have that interim, we'll call it biomarker, or almost disease that we could treat with a drug to prevent. And that would be, precancers or carcinogenesis or genetic risk. And we really need to start thinking in that way to develop strategies to prevent cancer. And I'll agree with the panelists that the cancer is a continuum that starts from your risk and evolves into cancer, and hopefully we can stop it before it gets to that point.
Great. So now, thank you. Walter Willett, who is known to many of you, will now tell you how to prevent cancer through a couple of small dietary changes, right? Walter?
Right, yes, okay. You know, I do actually quite a bit quite a bit of my work in cardiovascular disease prevention as well as in cancer prevention. And there is no question that breast cancer is more challenging than cardiovascular disease prevention. I could talk about that for quite a while, but it clearly changes in diet and lifestyle during midlife or even later life have a quite rapid effect on reducing cardiovascular disease, and it's not so clear-cut with breast cancer. But we have learned quite a bit. Basically, the two most important things, if no one in the U.S. used hormone replacement therapy and also did not gain weight after age about 20, then we'd reduce breast cancer mortality by about 50%, which is really big. So there is a, yeah, so there's some big challenges in how we
What made
implement
some
that.
of you didn't hear is that the expert sitting beside him said, "Dream on."
Right. But it is something to aim for, and of course there's lots of other benefits to doing that as well. For premenopausal breast cancer, it's more complicated. We're just starting to learn about the risk factors, and it's become quite apparent that a lot of them are operating during childhood and adolescence, and so prevention in the long term, I think, is going to have to start there. But I would toss out something that I think does need more discussion, is that actually for raloxifene, the best data suggest there's something like 50 to 70% prevention of breast cancer with that. And actually that's a lot more, statins reduce heart disease risk by about 25 or 30%. Raloxifene is actually much more powerful in preventing breast cancer than statins are, and yet we use statins massively. So I think we actually need to get back together amongst ourselves and think a little more deeply about about policies and using some of the tools that are available. I think we're not utilizing them fully.
Right, and so Walter was referencing Evista, which I bet a fair number of people in the room may have been given as a prescription by their gynecologist to treat osteopenia or osteoporosis, thinning of the bones. And it's a cousin, if you will, of tamoxifen, which is actually a drug proven to reduce risk in direct studies, as has now raloxifene been. And so this makes the point that prevention is possible, and prevention in breast cancer is possible.